The lecture series of Diabetes Mellitus. This first lecture is about introduction of Diabetes Mellitus. By the end of this lecture, you will be able to define Diabetes Mellitus, classify its types, explain the core pathophysiological mechanism, clinical presentation of Diabetes Mellitus, who to screen for Diabetes Mellitus, diagnose diabetes using standard criteria as per American Diabetes Association 2026 guideline. Diabetes mellitus is basically a combination of Greek and Latin word. Diabetes means excessive urine and mellitus, honeyed or sweet urine. During ancient time, the diagnosis of diabetes mellitus was made by testing the urine of the patient. But thanks to the laboratory advancement, now we are able to diagnose diabetes by analyzing the blood sample of the patient. Diabetes mellitus is a systemic disease characterized by hyperglycemia, either due to insulin deficiency or insulin resistance, or sometime combination of both. Because of impaired insulin secretion or insulin action, there is disordered metabolism of carbohydrate, fat, and protein. Because of dysregulation of carbohydrate metabolism, most of the clinical manifestation and complication of diabetes occur. Diabetes mellitus is classified into 5 categories. Type 1 diabetes, it is because of absolute insulin deficiency due to autoimmune pancreatic beta cell destruction. Type 2 diabetes mellitus is because of insulin resistance. The pancreas is able to produce insulin, but because of insulin resistance, insulin is unable to carry out its action. In insulin resistance, the pancreas compensates this insulin resistance by producing more insulin. But the capacity of pancreas to produce more insulin declined with the passage of time, and after 4 or 5 years of this compensation, this compensatory more secretion of insulin, the pancreas lost its capacity and pancreas develop relative insulin deficiency that leads to the manifestation of type 2 diabetes. Gestational diabetes, insulin resistance due to placental hormones. This type of diabetes occurs during the second and third trimester of pregnancy. It diagnosed in patient who is not previously suffering from type 1 or type 2 diabetes, and it is because of these hormones, the placental hormones, which are required for the growth of the developing baby. These patients, after delivery, their diabetes resolves spontaneously, but these patients are at risk of developing overt diabetes or type 2 diabetes throughout their life. Inherited form of diabetes, that is monogenic diabetes, a single gene defect. These includes MODY, maturity onset diabetes of young, neonatal diabetes, and certain type of lipodystrophies. And a long list of secondary diabetes. The most important pancreatic causes such as pancreatitis, pancreatic tumor, pancreatic surgery, systemic conditions affecting the pancreas such as cystic fibrosis, hemochromatosis, hemosiderosis in certain hemoglobinopathies such as thalassemia major. Endocrinopathies, this includes Cushing syndrome because of excessive production of cortisol, acromegaly because of excessive production of growth hormone, pheochromocytoma because of oversecretion of catecholamines that includes adrenaline and noradrenaline, glucagonoma, that is oversecretion of glucagon. There is a long list of drugs that are responsible for causing hyperglycemia and diabetes. The most important are glucocorticoids. Glucocorticoids are commonly used in number of allergic, inflammatory, and neoplastic conditions. These include dexamethasone, hydrocortisone, prednisolone, and they are responsible for causing hyperglycemia. Antipsychotics such as quetiapine, olanzapine, post-transplant immunosuppressive drugs such as tacrolimus, sirolimus, and glucocorticoid. So core pathophysiology, take the example of lock and key concept. Suppose every cell is a room having door with a lock. Glucose has to pass through this door to enter into room. Insulin is the key that opens lock of the room for glucose to enter into the cell, to enter into the tissue, to provide fuel for ATP production for energy generation. If the key is absent, that is, if insulin is unavailable, it is insulin deficiency and patient is suffering from type 1 diabetes. If the lock is malfunction, which is resistance to insulin action, and this lock malfunctioning is mainly because of the excessive accumulation of fats which prevent insulin to fit into lock and prevent door opening for glucose. So this is insulin resistance and the patient is suffering from type 2 diabetes. So the key is available, but the lock has become rusted. The lock has become malfunction. So there is insulin resistance, which leads to hyperglycemia and clinical manifestation of type 2 diabetes. Because of the impaired action of the insulin or absence of insulin, the disordered metabolism of carbohydrate leads to underutilization of glucose, which is present in the blood, and overproduction due to inappropriate gluconeogenesis and glycogenolysis. We know that insulin is required for the inhibition of gluconeogenesis in the liver, and insulin is responsible for storing excessive glucose by converting them into glycogen by process of glycogenesis. But because in the absence of insulin, there's constant gluconeogenesis in the liver and in the kidney, and there's glycogenolysis, which leads to further increase in blood glucose level. So basically, tissue deprived of fuel, which signal liver to produce more glucose by gluconeogenesis and glycogenolysis, further increasing blood glucose level. This leads to chronic hyperglycemia and toxicity, which causes damage to blood vessels and nerves, leading to complications of diabetes. Insulin is an anabolic hormone and is responsible for lipogenesis. In the absence of insulin action, there is lipolysis, breakdown of fatty tissue, causes production of ketones, which leads to acidemia because ketones are acidic, and this increases the risk of diabetic ketoacidosis in diabetic patient. There is increased production of free fatty acid by lipolysis, and this free fatty acid convert into triglyceride, causing hypertriglyceridemia and diabetes. Protein catabolism, again, insulin is responsible for protein synthesis. In the absence of insulin, there is protein breakdown, and this leads to loss of lean muscle mass. Amino acid utilized as substrate for gluconeogenesis, and this is because of lipolysis and proteolysis, the diabetic patient lost weight. Clinical presentation. Type 1 diabetes, this type of diabetes mainly occur during early childhood, during adolescence. But remember that type 1 diabetes may occur at any age, even in elderly population. But the presentation in adulthood or in elderly is not very dramatic. In younger people, in younger children, type 1 diabetes present with the classical features of diabetes such as polyuria, polydipsia, and loss of weight. And more than 85% of the children present with a dangerous complication of type 1 diabetes, that is diabetic ketoacidosis. The phenotype of the patient is lean, thin individual. Type 2 diabetes is a slowly evolving diabetes. It mainly occurs in age more than 35 years. The diagnosis of type 2 diabetes is delayed for 4 to 5 years. As I have said earlier, the insulin resistance is compensated by pancreas, and because of this compensation of pancreas, the diagnosis of diabetes is delayed for around 4 to 5 years. Mainly type 2 diabetes are diagnosed incidentally by elevating the blood glucose level of the patient for certain other reason or during hospitalization for certain other causes. The phenotype of the patient is mainly obese or overweight. Clinical presentation of diabetes mellitus is because of hyperglycemia. Hyperglycemia is the main driver of symptoms. We know that blood glucose level is osmotically active molecule. The kidney has a limited capacity to reabsorb blood glucose. If there is an excess amount of blood glucose, the excess amount will be excreted out in the urine. And we know that glucose is an osmotically active molecule. It causes diuresis. It causes excretion of water along with its excretion in the urine. So because of this diuresis, the patient has increased stress because of the loss of water in the urine due to the glucose excretion due to glucouresis. The patient has increased stress, so polyuria, polydipsia, fatigability, generalized weakness, and sleepiness. The tissues are deprived of glucose because of absence of glucose to enter into tissues to available for the energy production. This leads to fatigability, generalized weakness, and somnolence. Blurring of vision. They could be transient causes or irreversible permanent causes. The transient causes include in hyperglycemia, there is an osmotic shift of fluid into the lens, which swollen the lens, and because of the change of shape of the lens, the patient develop blurring of vision. If you correct the blood glucose level rapidly, the reverse can happen, and the amount of fluid in the lens shift back into the surrounding tissue, and again the shape of the lens has changed, and the patient again feels blurring of vision. This is usually transient, and this subsides within 4 to 6 weeks of correction of blood glucose level or hyperglycemia. The more serious and irreversible causes of blurring of vision include retinopathy, macular edema, cataract, glaucoma, and certain type of cranial nerve palsies. Because of peripheral nerve toxicity of glucose, patient may feel paresthesia, pins, needles, numbness in extremities. Recurrent skin infection, UTI, and genital fungal infection. We know that hyperglycemia affects all the component of immunity. It affects the cellular immunity, humoral immunity, and we know that because of the chronic toxicity of blood glucose level, hyperglycemia, it affects the vessels, it affects the nerves. So because of the vascular compromise, because of the neuropathy, these patients are responsible, these patients are prone to develop recurrent skin infection. Delayed wound healing, the advanced glycated end product, the glucose irreversibly bound with the elastin and collagen, and because of this advanced glycated end product, the tissue loses elasticity and the tissue has become stiff, and this accumulation of advanced glycated end products along with neuropathy and vascular compromise, the patient have delayed wound healing and impaired immunity, also contributing to delayed wound healing. Weight loss, as I've said earlier, there is lipolysis and proteolysis which causes weight loss. Most of the type 2 diabetic patients are diagnosed incidentally, and they are mostly asymptomatic, and most patients are diagnosed on screening. So, who to screen for type 1 diabetes? Those individuals who have family history of type 1 diabetes, if there is history of diabetes, type 1 diabetes in the mother, in the parents, in the siblings, then these patients are at risk of type 1 diabetes. They should be screened for type 1 diabetes. In presence of predisposed genetic risk factors such as HLA class 2, DR3, DQ2, DR4, DQ8, and class 1, BB or B15. If the patient carry these haplotypes, they are at risk of developing type 1 diabetes. So these individuals should be screened for type 1 diabetes. The rationale or purpose of type 1 diabetes screening is threefold. Number one, more than 85% of type 1 diabetes presented with diabetic ketoacidosis. Diabetic ketoacidosis is a very serious complication of type 1 diabetes, and in underdeveloped countries, the mortality of diabetic ketoacidosis exceed more than 15%. So by identifying those individuals who are at risk of developing type 1 diabetes, we could prevent diabetic ketoacidosis and we could prevent patient admission into the ICU. Number two, to enable intervention or preserve beta cell function. In number of trials, it has been suggested that the monoclonal antibody teplizumab, if given in stage 2 type 1 diabetes, that is, if the autoantibodies are present and there is dysglycemia, there is no overt hyperglycemia or clinical manifestation of type 1 diabetes, just the blood glucose level in the pre-diabetic range. So if you give them teplizumab, this will delay the clinical onset of stage 3 type 1 diabetes for around 2 to 3 years. And number three rationale is that by giving this monoclonal antibody, you will gain time for the family to educate themselves about type 1 diabetes, because type 1 diabetes, the family, the caregiver, the patient requires extensive education how to manage type 1 diabetes. It requires lots of education, lots of training to the family, to the caregiver, to the patient, that what is the purpose of insulin, what is the sick day rule, what steps should be taken during hypoglycemia, what is the effect of physical activity or exercise during on blood glucose level. And so screening of type 1 diabetes involve autoantibodies testing. The first step is you do not check for blood glucose level, you check the anti-islet cell autoantibodies. So these are the four autoantibodies: anti-GAT65 antibody, anti-islet antigen 2 antibody, anti-zinc transport 8 antibody, and anti-insulin antibody. If two of the antibodies are positive, then you check the plasma glucose or HbA1c to assess for overt diabetes or dysglycemia. Who to screen for type 2 diabetes? Patient age more than 35 years, any patient with higher BMI, that is if BMI is 23 or above for Asian and 25 or above for non-Asians. The lower BMI indication for Asian is because we Asians are prone to develop diabetes at relatively lower BMI because of excessive accumulation of the fat into our viscera because of the central obesity. So if patient having higher BMI with any of the following risk factor: first degree relative with diabetes, high risk ethnicity such as Asian, African, hypertension such as the blood pressure is more than 130 by 80, high density lipoprotein less than 35 milligram per deciliter, or triglyceride more than 250 milligram per deciliter, any patient who have cardiovascular disease, female patient with polycystic ovarian syndrome, and any individual who have higher BMI with sedentary lifestyle, and if there are features of insulin resistance such as obesity, acanthosis nigricans, metabolic dysfunction associated steatotic liver disease. If initial screening normal, then repeat after 1 to 3 years. If pre-diabetes, then yearly screening is required. Gestational diabetes mellitus history, then 1 to 3 yearly screening. High risk group required close monitoring. These high risk group include pancreatic disease, HIV, high risk medication exposure, and periodontal disease. So for screening of diabetes, there are two types of blood tests are used. Plasma glucose, this includes fasting plasma glucose, random plasma glucose, and 75-gram oral glucose tolerance test. And the second test is HbA1c. Asymptomatic patient, fasting blood sugar after 8 hours of fasting, if it is 126 or above, then the patient is suspected to have diabetes. If the random blood sugar is 200 or above, or if the 2-hour plasma glucose after 75-gram oral glucose tolerance test is 200 or above, they are suspected to have diabetes. Since the patient is asymptomatic, then the confirmatory test is also required. The another test for HbA1c is if the HbA1c is 6.5 or above, then the patient is suspected to have diabetes. Repeat confirmatory test is required to make diagnosis in asymptomatic patient. Repeat of the initial test or different screening tests. Suppose if the fasting blood sugar is 126, then you could repeat the fasting blood sugar to confirm the diabetes. Suppose if the fasting blood sugar is 126 and you check the HbA1c, and if it is 6.5 or above, then the diagnosis of diabetes is confirmed. Both abnormal result, diabetes, either same test or two different tests. Problem arising with discordant result. One normal and other abnormal, then screening test with higher diagnostic cutoff point should be repeated. For example, if the fasting blood glucose is 110 and HbA1c is 6.6, 6.7, then HbA1c should be repeated to confirm whether this higher cut point of the HbA1c is because of certain interferences, lab error, or the patient is suffering from diabetes. Most sensitive test in diagnosis of diabetes is 2-hour plasma glucose, 75-gram oral glucose tolerance test. So the OGTT test is the most sensitive test. This is very, very important to remember that, because in most of the exam, these questions are asked, what is the most sensitive test of diagnosis of diabetes? So oral glucose tolerance test is the most sensitive test in the diagnosis of diabetes. Preferentially recommended for screening of some condition, example cystic fibrosis, post-transplant diabetes. In oral glucose tolerance test, this could be falsely positive if carbohydrate restriction prior to test was done by the patient. Patient with classic symptoms of hyperglycemia such as polyuria, polydipsia, weight loss, or hyperglycemia crisis such as DKA, HHS, and RBS is 200 or above, then confirmatory test is not required. Fasting plasma glucose and HbA1c more visible compared to oral glucose tolerance test, and in most of our clinical setting we use fasting plasma glucose and HbA1c for the diagnosis of diabetes. Remember, fasting plasma glucose affected by stress, physical activity, nutritional status, or illnesses. That's why repeat testing of the fasting plasma glucose is required. Glycolysis, which result false negative testing if sample not processed promptly. Remember, HbA1c is affected by a number of conditions. Any condition that affect the lifespan of the RBC will result in erratic HbA1c level. So by anemia, hemoglobinopathies, pregnancy, blood transfusion, dialysis, etc. So these are the different value of blood glucose level in normal, pre-diabetes, and diabetes mellitus patient. So if the fasting plasma glucose is less than 100, it's normal. If it is between 100 to 125, then it's pre-diabetes or impaired fasting glucose. And if it is 126 or above, then the patient is suffering from diabetes mellitus. If the random blood sugar is less than 140, it's normal. 140 to 199 is pre-diabetic, and 200 or above is in the diabetic range. If the HbA1c is less than 5.7, it's normal. If it's between 5.7 to 6.4, it's pre-diabetic. And if it is 6.5 or above, then it's a cutoff value for diagnosis of diabetes. Oral glucose tolerance test, if the 2-hour blood glucose after 75 gram of oral glucose less than 140, it's normal. If it is in between 140 to 199, it's impaired glucose tolerance or pre-diabetes. Or if RBS after 75 gram of oral glucose after 2 hours is 200 or above, then the patient is confirmed to have diabetes. So this was the initial lecture, and the second lecture is about from screening to specific diagnosis. Remember, the diagnosis of diabetes is easy, but categorizing the specific type of diabetes is very crucial, is very important, because each of the different type of diabetes vary in its clinical presentation, its response to different anti-diabetic medications, and the risk of complications also vary among different type of diabetes. So if you wrongly categorize diabetes, then the patient may suffer from complication of diabetes and their blood glucose level will not improve. So thank you so much for your keen listening.